We are Good evening to everyone. I am Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this new interesting session of no thrombosis. We have seen every monthly we are discussing very interesting live inbox cases. Today is a very special occasion and a very special edition. Two of the former CSI president has been joining this program, and I could see a very interesting discussion coming forward in this program. So it gives me a pride, privilege, and honor to welcome our post director, Dr. MS Hiremat sir. We all know Sir is a director at Cath Lab at Ruby Hall Clinic, Pune in India. Sir has been a former president of CSI 2017 and convener for the National Interventional Council of India of CSI from 2004 and 2006. Sir had proctored many interventional cardiologists and has given live courses across the globe. Though Sir is a coronary interventionalist at heart, he is equally adept at peripheral arteries interventions like leg, carotid, and aorta. And Sir has been a part of many groundbreaking trials and many articles on his credit. And I wish to, and I must say, Sir's keen interest always keeps us motivating to identify new faculty, to get the new interesting cases in this program. And Sir's discussion and Sir's point, which is very, very important at real life scenario, brings a lot of learning and wisdom out of this program. And I think this is the key. And CSI chairman of the organizing Sir had
Recording in
published
progress.
many articles, hundreds of articles in reputed journal and including international journals, and also the textbook of the cardiology, and also edited updates of cardiology. Sir has been a regular speaker of various national and international conferences of cardiology. It's our honor, sir, you being a part of this program, and we look forward you and Hiremat sir in this program. It would be a great and very rich program which we will be cherished for certainly for a few months to come. Thank you very much, sir. At the same time, I would like to welcome our moderator, Dr. Girish Nausundi, sir. Sir will be joining at any time. Sir is joining with us for last 2 to 3 months, and sir is currently director at Cath Lab and senior interventional cardiologist at Apollo Hospital, Bangalore. Sir has been performing many coronary angiograms and through femoral, radial, and ulnar approach, and about maybe more than 2,000 angioplasties, both coronary and peripheral. And Sir is the first cardiologist to implant a SCOP stent in a private health sector in a state of Karnataka, and also first cardiologist to implant MRI compatible AICD system in the state of Karnataka, and also the first to implant tapering coronary stent in the state of Karnataka. Sir has been always with us at Emcure and be a part of our no thrombosis program many times. Now, I wish and welcome our speakers for the day. Our first case presenter would be Dr. Abhishek Sanklecha. He is a consultant interventional cardiologist at Medicover Hospital, Nashik, and Rhythm Heart Center at Nashik. He has very interesting topic to present. He will be presenting Try and Try, You Will Succeed, Complex Multivessel PCI with Bifurcation Stenting. Our second speaker and faculty for the day is Dr. N.V. Gaurishankar Reddy. He's an interventional cardiologist at KIMS Icon Hospital, Visakhapatnam, Andhra Pradesh, and he will be presenting LM bifurcation. Our third faculty and the speaker for today's meeting is Dr. Vikrant Khese. He is an interventional cardiologist at Vignaharta Heart Care and Imaging Center, Pune. He will be presenting on acute coronary syndrome, still a valid contraindication to perform a rational arthrectomy. So this would be the topic for Dr. Khese. So this would be the flow of our program. So Dr. Sanklecha would be presenting first, and then Dr. Reddy, and then Dr. Khese. So at this point of time, I will stop, and I wish to have the comments by our course director, Dr. Hiremat sir, and also followed by Dr. M.K. Das sir. Over to you, sir.
Hi, Dr. Das.
Hi, good evening. After a
Seeing you
long
after
time, we are
real.
seeing you.
Actually, we worked together when I was president, and Dr. Das held this meeting in Calcutta, and it was an outstanding meeting. And we had a very 1 year of strong friendship, understanding between West and East, and just loved Dr. Mrinal's association with the CSI. So let's continue, Dr. Omkar.
Yes, sir. Yes, sir. So,
Mrinal, your first time with us?
yes, sir.
Yeah, that's
Very
right.
good. Welcome.
And we wish sir will continue with us for a few more months, and that would be really interesting program. You, Dr. Das sir, and Dr. Nausundi sir, he has also joined. So I think, sir, with your kind permission, shall we move to the first case of Dr. Abhishek?
Just before you start, one comment regarding Dr. Hiram, because he commented about me. Actually, I had the best relationship with the president of CSI in my 3 years career as the general secretary of CSI. And we had really done good job during that time. And he is always, very accommodative and cooperative, and also very congenial to everyone. That's his classic signature. With that few words, you start the program.
Thank you very much, sir.
Thank you.
So, I would like to invite Dr. Abhishek to take his case.
medicine change.
Yeah. So good evening, all the respected faculty, Hiremat sir, Das sir, and Nausundi sir. And thank you, Emcure, for providing me this opportunity to present my case and learn from the stalwarts in the field of cardiology. So I'll go to sharing my screen. Am I audible?
Yes.
Okay, thank you.
Yes, your slides are also visible. You need to make it to full mode.
Yeah. Is it full screen now?
Yes, you can go ahead.
Yeah. So I'll go ahead with my case. I have named it as try and try. You will succeed. We'll see through the presentation, and we'll know why I have given this title. So my patient, 60-year-old male, diabetic, hypertensive, presented to us with a history of recent anterior wall MI, thrombolized elsewhere, with history of post-MI angina. Echo was showing hereditary hypokinesia with preserved LV thickness and with overall LVEF of around 45%. So we took the patient for cardiac catheterization. The LCA was engaged via the right radial approach with 5 French Tiger catheter. This is the areocaudal view showing the left main dividing into LAD and circumflex. The distal left main shows mild plaque, which continues into the ostial LAD. Proximal to mid LAD near the origin of the diagonal is showing severe disease. The distal LAD appears to be free of significant disease. The diagonal ostium is diseased around 6 to 7, more than 10 mm. Along with that, the circumflex is a non-dominant vessel. It is showing a proximal severe disease. It continues into a major OM. Major OM gives the multiple branches, which is having mild plaque, and the circumflex is diminutive. This is the epicranial view, which confirms the severe disease in the proximal to mid LAD and the diagonal. So it is a bifurcation disease with Medina 011. The RCA was also engaged with Tiger catheter. This is the iliocranial view showing distal plaque, the crux and distal PDA PLVs free of significant disease. So we planned this case as a dedicated bifurcation, LED D1 bifurcation using the DK crush technique followed by PTCA2 LCX. So the left coronary artery was engaged via the femoral axis with 7 French EBU 3.5 guiding catheter. The both LED and diagonal, both branches were wired and dilated using the BMW wire and 2.5 15 balloon. This is the angio after pre-dilatation of both LED and D1. As we can see, both branches have opened up well. There is some dissection tram tracking in the mid LED, but both of the branches are flowing well. So the side branch diagonal was stented with the 2.5 16 des, and it was the balloon 312 was taken in LED to crush the side branch stent. So this is the picture. First picture is after the deployment of the side branch stent. The side branch is flowing, and there is no distal dissection, and the disease appears to be well covered. There is a 2 to 3 protrusion of the side branch stent into the main vessel. So the diagonal was rewired via the proximal strut, and the balloon was taken, 2.512 balloon was taken for to as a part of first kissing balloon inflation. So at this point of time, there was a mistake from my end. I happened to dilate the ostium of the diagonal. So because of that, what happened? I could not take the second LED balloon, which was meant for kissing inflation, first kissing inflation. So the cause of it was maybe I have opened up the proximal LED stent towards the proximal diagonal stent towards the LED. So there was no space for passing the material 312 balloon into the LED. So a space was created using a small 1.28 New York balloon. After that, my balloon went away into the LED. So the first kissing balloon inflation was done with a 2.512 balloon in diagonal and a 312 balloon in the LED. So this is the first kissing balloon inflation. Then the LED stent was taken 3 into 33, and this is the stent. This is the picture after the deployment of the LED stent. The disease appears to be covered, stent appears to be expanded well, and there is no distal dissection, and both vessels are flowing well. Proximal optimization was done in the LED with 3.58 balloon to facilitate the recrossing into the diagonal. So again, diagonal was rewired. There was a difficulty in rewiring the diagonal. It took me around 15 to 20 minutes to rewire the diagonal. Maybe there was it was again and again going to the through the proximal strut. I wanted to go to the distal strut. Um, After 3 attempts of rewiring, the balloon was not going. Small 1.28 balloon was not going into the diagonal. So I had to rewire 2 more times, and finally the balloon went away. This is the 1.28 balloon. I am opening up the ostium of the side branch. So after that, I took 2.512 balloon into the diagonal and 312 into the LED, and did second kissing balloon inflation. So this is the picture after the deployment second kissing balloon inflation. Both vessels appear to be flowing well, and there is no dissection, proximal or distal dissection. So final pot was done with 3.858 balloon in the LED, and this is the second picture is after the final pot. This finishes the intervention for LED diagonal bifurcation. Then circumflex was wired with 2.5 into 12 circumflex was wired and dilated with 2.512 balloon. Regulating stent 3.523 deployed. Then again the 3.58 NC done, and this is the result in the circumflex. The disease appears to be covered well, and there is no dissection. This is the final result. This is the areocaudal view showing all the three vessels flowing well. There is some disease in the distal left main and a plaque in the osteoproximal LED, but we kept it on medical management. So this is the final result. So
Did you
what
do
I
an FFR? Did you do an FFR to RCA?
no, sir, it was not done. Actually, we do not have the facility to do the FFR. It was not done, sir.
It's very easy. I mean, all that you need is a wire, and the company is very keen on putting FFR at as many places as possible. When you have to make a decision in cath lab, I always like to use FFR. Earlier, we used to wait, send the patient for stress thallium, and then sort of make a decision whether right needs an angioplasty or no. But these days, the problem is solved in the cath lab itself when you first do ad hoc angioplasty. So in your case, LAD and circumflex would get a stent the way you have done, and FFR to the RCA. I think it's a reasonably reliable test, though many times it comes negative. I mean, what we feel with eyes that it's important, the FFR may come negative, but I guess we go by science and leave those lesions, and a close follow-up is necessary. Ronald, any comments from you?
Yeah, I think you are absolutely right. The FFR on the RCA could have given some clue, but I was keen to see the FFR in the LCX as well, because I was not sure whether the LCX was really having the kind of FFR less than 80 or like that. If it could have been taken, possibly it would have been better. This is number one. And number two, one will have to prepare oneself very meticulously and concentrate on the different aspects of the procedure. Say, for example, the mistake which was admitted by Abhishek, that instead of putting some, the balloon or balloon in the LED, straightway the inflation was done on the D1, and that really created a lot of problem. And in fact, at the end, he could not dilate it exactly to the full, which you could have done easily later on. That's why there was a sort of proximal D1 sort of, it was a somewhat less diameter as compared to the mid part of the D1 after the inflation and after putting the stent. So otherwise it was done fantastically, and it is very appreciable that Abhishek has done excellent job in a very, very critical patient who had post infarct angina.
Dr. Abhishek, the other thing I would like to say is when you put the side branch stent first, as you did in this case, I think the stent balloon, you should withdraw maybe, say 2 millimeters back, get fully inside the stent, and same balloon you can go on high pressure. Many times it's difficult to take another balloon into the deployed stent. So, I mean, if it goes well and good, but at least before coming out, the same balloon go high pressure after withdrawal of 2-3 millimeters. And that, because this is a ostial stent, ostium of diagonal, has to be stretched fully. And that's why withdraw so that you don't dissect distally.
Yes, sir.
Very well done. I think
The patient has come for first follow-up after 1 month, and he's doing well at present. And I'm planning a angio after 3 months of follow-up, elective angio.
why?
Sir, it is not indicated according to the guidelines, but I have heard on various forums that whenever you do a complex intervention, you should electively do an angiogram to see what are your results after 3 months or maybe 6 months.
I mean, if it is for learning purpose, I mean, your own learning purpose, it's understandable. But I doubt if patient is quite good, maybe you can do a stress test at between 3 and 6 months. And
Yes, sir.
if that is good, I think probably carry on.
Yes, sir.
Another, Abhishek, did you face the slow flow in the LAD while doing the procedure?
Why are you asking this, Mrunal?
Yeah, I'll tell why I'm asking this, whether he faced it or not.
No, sir. Patient fared well tolerated the procedure very well.
That's fantastic. So if that is so, then Dr. Hirema's opinion is absolutely acceptable, because since there was no slow flow, which is indicative of some of the coronary microcirculation problems. So in that case, there may be some indication later on whether there is any factor causing further the instant problem or not. Now, since there is no such slow flow, so automatically you can go with the stress imaging or like that, so that you can guess about the condition of the stents that you have done or you have
Mrunal,
put
do
it
you
in.
use intracoronary antiplatelet agents like tirofiban or eptifibatide? I mean, in ACS situation, we do expect thrombus. Abhishek, in your particular case, the instability or the unstable nature of your coronary pain was coming from LAD diagonal bifurcation. So I would probably feel that a small bolus of tirofiban or eptifibatide could be given intracoronary. We could do it pretty often. I don't know whether Mrunal does it or Dr. Nosandi does it.
Yeah, well, Dr. Hiremath, actually, we used to give this eptifibatide earlier, say quite some time back, means many years back. Now, with the introduction of the ticagrelor, actually, we are not using it much. That's what I was discussing with Omkar also, that we are not using it much. Because we don't find any problem with the introduction of the
No, Mrunal, I would feel many times the ticagrelor is given on table, and it would take some time. At least I feel it takes at least 1 hour to get a good action. So whenever you are doing SOS, like you do an angio, discuss with the family. I mean, when I go out to talk to the family, my nurse is already giving 2 tablets of ticagrelor to the patient, because more the time, the better is the action. And that's why even before I discuss with the family, 2 tablets are gone. At the end of discussion, if the family agrees, we come back and we have gained about 15-20 minutes of action of tricycle.
Sir, I usually use a GP2B3A as a bailout if during the procedure there is thrombus or if there is no flow or slow flow. But electively, I'm not using, sir.
No, I think we all look at the main vessel, like in this case, LED and diagonal were the main area of culprit. But you also have microcirculation, which
Yes, sir.
is probably getting small emboli from the lesion all the time. And also during angioplasty, we push down tiny clots. So I think it's safer or better, I would feel, to give some kind of GP blocker intracoronary, but not guideline directed. It's just my personal. I hope
Sir, in
Mrinal is.
all,
Yeah, absolutely well taken. Definitely in some situations, as Abhishek mentioned, that if we feel that there is evidence of slow flow or like that, or instant possibility of instance the thrombus is also there, then definitely it is there is no other option we can use it. But since Dr. Hiromati is much more experienced and he is using, he has seen many cases. Possibly, I'll agree with him that his experience should be given due recognition.
The microcirculation flows are very difficult to judge on our conventional angiogram. And I would feel when you have an enzyme rise, ACS situation, the microcirculation has some clots. So these small bolus will probably take care of those microcirculation clogging.
Absolutely,
yes,
absolutely.
All right. Anyone else has any comments, questions, Dr. Onkar? From the audience, are there any questions?
No, sir. There's no question. So maybe
Right.
we can move to the.
Thank you, Dr.
segment.
Abhishek. Really
Thank you,
enjoyed
sir.
your case.
Thank you,
Thank
sir,
you,
for your
Abhishek.
inputs. Thank you, Das, sir.
The
Hiromati, sir.
important issue in this case is this patient will go home believing that you've done a great job. And one day he will come with an inferior wall infarct from the right coronary artery. So
Yeah.
you have to get the LDL absolutely down,
Yes, sir.
whatever ways in which you can get it down. And in
Yes, sir.
addition, follow him. Like I would feel a stress test at every year is very important to decide if right is open, remaining open, or is giving ischemia.
Yes, sir. Thank you, sir.
So let us move to the next case. So Dr. Reddy will be presenting the next case. So Dr. Reddy, are you there? Yes, he started.
Yeah, good evening, everyone.
Good evening.
Yeah, my name is Dr. Gauri Shankar and consultant interventional cardiologist of KIMS Hospital, Visakhapatnam. Today, my topic is actually LM bifurcation is there because of stuck with some slides and everything. So the dealing calcified lesions with the ultra high pressure balloon based case-based approach, I'll tell you. So the case one is there is history-wise is the name, some certain name is there. He's 82 years old man. His presentation was shortness of breathing. He was diagnosed as old anti-wall MI. His LV dysfunction. He was severe LV dysfunction. The risk factors were diabetes and hypertension. And after that, we have done the stress thallium. There shows like non-viable LAD territory. So these are the angiogram of left side system. You can see that there is a critical stenosis of the left main. There is austral LAD total occlusion. And there is a big OM is there. And the big circ is there. So what I plan is initially the patient was not willing for the imaging. So we tried with the routine balloons and but we used the wire was Renato wire. The guide was 7 French guide. Then we put the wire side branch, jailing wire kept in OM. Then we pre-dilated with 2.5 and 12 balloons. Then you can see that clearly there is a dog bone resistance. You can see that in the. So the plan was LM to L6 is LM crossover stenting is the plan. So then after that we deployed the stent and you can see that clearly there is a residual stenosis is there. There was no pinching. Then we use the ultra high pressure balloon OPNC balloons, 3.54 balloons I use. Then followed by that part you have done with that 4.5 and 5 balloons in the left main. See that this is the OPNC balloon I use. There is a clear cut yielding is happened. After that I have done the part. This is the final result.
Try going full screen. I think it might run.
There is some problem playing. This is the final result. You can clearly see that clear cut yielding. You notice that in that. There is one more case. This is a 72 years old.
Doctor, just 1 second. The LED was not pinched at the end of stenting from left main to circumflex.
The LED is still total occlusion, sir. That was there is only L6 and OM is there for the patient.
Oh, that's OM, is it? Okay. I thought the LED territory was also non-viable. That's
non-viable. So 82 years old man. Then we planned for that LM to L6 LM crossover stenting we planned.
Okay.
There's one more case, and this is a 75 years old man presented with unstable angina. His risk factor is diabetes and hypertension. It was done with angiogram. It showed like osteal RCA 90%. There is heavy circumferential calcification. You can see that in pre-dilated with the 3x12 with balloon, NC balloon we have done. After that 3.524 Xan's expedition, we deployed the stent and dilated with 4x12 NC balloon. But still there was some residual stenosis was there. Then after 6 months again he presented with unstable angina. You see that again the patient there is a significant of osteal RCS stenosis is there. Even if you see that in IVUS also there is a clear cut of minimum lumen area is almost like 4.73. See that. So vessel diameter comes under 4.7. So again we planned with one more intervention. The lesion was first dilated with 3.512 cutting balloon with 14 atmospheres. Still there is no luminal gain. See that OCT image RC ostium. Still lumen area is MLA comes 4.85. The vessel size roughly comes into 4.5 to 5. So we planned intervention. We used the first ultra high pressure balloon, OPNC balloon. Initially we used for the 4x10 balloon. So gradually inflated and the residual stenosis gave up to 40 atmospheres. The RBP comes 35 atmosphere for that. You can go up to 40, 45 also OPNCs, no problem. So this is the 4 balloon I use. After that yielding started. So I was demonstrated clear the cracks in the circumferential calcification and the MLA comes around 6.68. So after that we followed by implantation one more stent to provide that radial support. We use the 4.510 Xan's expedition. And after that we deploy the stent. We use again 4.5 NC balloon. We go up to 16 atmospheres. You can see that MLA comes around 6.8. 6.68 and the vessel size is 4.7 in the IVUS. So the final result showed there is no residual stenosis, though IVUS is demonstrated the fully open stent with MLA of 14.12 square mm. These are the images. The videos are not available. So what I want to conclude is patients with complex calcified lesions, if it is undeliverable lesions, ultra high pressure OPNC, you can use for the plaque modification, followed by stent implantation. We can achieve that maximal lumen gain for the best short and long-term outcomes. This is what I want to conclude. So dealing calcified lesions is not that simple. So when you deal the calcified lesions means you have to prepare for all the material. And second thing, without imaging, if you deal calcified lesions means definitely you will be in very high risk. So if it is imaging centers not available in centers, so you be ready with that of covered stents and all the material. If it is balloon passing, it's okay. If it is balloon is not passing means you have to use the rota. If it is balloon passing, if it is imaging wire is passing, then you can see that imaging based on that, whether you go for the OCT or whether you go for the IVAS. Based on that, you can clearly plan the management properly. If it is imaging is not available, better you avoid and go for the where the imaging centers are available. That mainly why I'm presenting this case is the opinions is not negligible things nowadays is to crack the calcium means people using IVAS, people using rotas and IVL. So when it comes to cost factor, the IVL it is costing 2.75 lakhs and the rota also comes 2 lakhs. But when it comes to OpenMC, it is costing maximum for that MRP cost is 40,000 only. So you can try with OpenMC balloon offer if it is any residual stenosis there. You can get the better results and financially helpful to patients. Thank you.
Dr. Gaurishankar, you took great care once the patient came back with an ISR. I'm talking about your second RCA ostial lesion.
Yes, sir.
Why you didn't take the same steps or same care when you did the first time? Because ostial RCA, a dominant vessel, big vessel, I think it needed all the steps that you did the second time when it came.
I used the second case actually imaging. That's why I planned properly.
No, ostial RCA, I think you must. I mean, it behaves more like aorta, and no balloon, whatever you do, can do what a cutting balloon or a rota can do. The other thing I would suggest is when you're using very high pressure on the OPNC balloon, something like 40 and 45, the balloon sticks to the wire. So the wire that you take generally should not be hydrophilic. There are some people who say that it's very difficult to pass the lesions, so I used a hydrophilic wire or a wire which has some kind of hydrophilic coating.
Yeah.
So in that case, put another wire on the side because as you deflate and you try to go negative, if the wire is stuck to the OPNC balloon, it will pull out the wire. So when it gets pulled out, if you have wire on the side, that would still be quite safe. So I would probably feel this is an extra care that you take when you go really high on OPNC.
Okay.
The other issue is OPNC, whether Mrunal, you could answer this question for us. Do you take a regular wire or you take a hydrophilic wire or whatever? It doesn't matter to you.
I use
it matters because if I am anticipating the ostial stenosis, in fact, after the first injection, if I find that it is so, then definitely I'll be choosing an hydrophilic wire rather than hydrophobic, because of the fact that it is easier to be negotiated and it goes automatically. So that is that is the choice for me. But the thing is that what I was actually thinking about the case at the very first instance, when I found that it was an ostial stenosis, then possibly I should have gone to the full strength, with full strength, to take care of that, because there are so many complications which might arise out of the lesion, including the dissection and all these things. And naturally, if it since it was diagnosed to be having a calcified lesion, automatically the chances of complications were more, and that's why possibly it could have been deferred for the second option, that is under IVAS. That case should have been tackled right from the beginning, rather than going for something like putting the stents initially and then wait for 6 months or so. So that was my feeling. But another thing is that this OPN balloon with so much of high pressure, definitely I'll be a little bit reluctant. Rather than that, I'll be going for other options, and especially if the case is done now. There are many other options, including the this what is called the body wear technique or the cutting balloon technique, and all these things will be tried here first, and then of course the bed will be made compatible for putting the stents.
A wire on the side, many people feel it works like a cutting balloon. I have my own doubts whether it makes so much difference, because cutting balloon has a blade and putting wire on the side is no comparison. So I would probably feel wire, if your first wire on which you're taking your OPNNC balloon, the OPNNC has this tendency that you go very high on pressure. That is the purpose why you're taking OPNNC. So when you deflate, if it is a hydrophilic wire, it sticks from inside. So whatever you try, when you pull out the balloon, the wire has a tendency to come out. So preferably have a wire on the side.
No, great advice, sir. I have had many occasions where pulled out the balloon, and OPNC balloon and wire has come out. I think this is a great advice.
No, many occasions are occasional occasion.
I get it. Thank you. And another thing, as you truly said, keeping a wire or two wires and using an NC balloon will not give you an effect of cutting like a cutting balloon. See, there were scoring balloons, but they really don't give you adequate cut into the the media. When the Boston people launched this Wolverine balloon, which is a truly cutting balloon with a blade, the atmosphere pressure that goes onto that blade is 3 times the pressure in the rest of the plastic balloon. That means if you got 15 atmosphere in the balloon, the pressure on the edge of that blade is 45 atmospheres. So that is why it is so effective compared to any other cutting balloon. So it's very
Dr. Nosindi, I don't know whether pressure is needed, because you have a blade which is very sharp.
Right.
And we had a new nurse, and she did not know that there is a blade on the balloon. So when she was cleaning the stuff at the end of the procedure, she cut her finger, and then she realized the balloon was sticking out. So it's a very sharp thing.
Very
And
true.
I don't think you need to go high on pressure. You just stay whatever pressure is written on the cutting balloon. And it should be 1-to-1. You can't take 2.5 cutting balloon for a vessel which is 3+ or 3. It should be 1-to-1. So 3, the cutting balloon also should be 3.
Very true. What the company says, sir, the smaller the area, the pressure transmission is going to be much larger compared to a rounded balloon applying the pressure on the plaque versus a sharp edge applying the pressure. It will cut through and disintegrate the constricting band of the lesion. That is why cutting balloons have been so effective. And also, as you rightly said, taking the balloon, when you deflate or inflate, normally we go at the atmospheres of what is mentioned, but usually about 0.5 millimeter less than expected, because you don't know where the balloon the blades would cut through. If the calcium doesn't yield, if it goes to the opposite side, it shouldn't harm the vessel. Probably 0.25 or 0.5 lesser would be safer.
No. I want everybody to be very clear. Take 1:1. I mean, whatever the vessel diameter you have measured, like you measured 3, take a 3/0 cutting balloon and use exactly the pressure which are mentioned on the flow chart and go to that pressure. Don't go higher, don't go less. If you go less, you are probably wasting the cutting balloon. And if you go to the correct diameter, you are making a good cut in the tube. So I think there is a little bit of learning in this cutting balloon business also. Always when you take this balloon out, try and see if the blade is on the balloon. Sometimes the blade slips. There have been cases where the blade has slipped and it's a disaster, losing a blade in the coronary and having to retrieve it. So I think all these steps are very important steps as we learn to use cutting balloon.
Dr. Hiremoth, just one question. What about the use of rota in this particular case?
I think it would have worked very well. I think many cath labs are sort of relatively new, operators also relatively new, and solo operators trying to do rota sometimes is challenging. But if you are doing rota to RCA, I would always have a temporary pacemaker in, because I think it does produce slow heart rates and even complete heart block for a while. So always have a temporary pacemaker.
Makes sense, sir. I think the dealing with the calcium, imaging is the tool. If the today rota, we primarily focus on non-crossable lesions, but crossable lesions, superficial calcium, I think cutting balloon is good enough. But if you image and show that there's a thick calcium, I think nothing like rota. And then the circumferential, deep, thick calcium, OPN may not help you. You will need IVL. You know, this was the case, you got away. But if there is a circumferential 360-degree calcium with more than 5 to 10 millimeter depth, I don't think even OPN can crack that.
Yes, I think so. There are 3 options. One is your cutting balloon, one is a rota, and third is an IVL. So IVL can hit the deep-seated calcium. The cutting balloon is probably superficial calcium, and so is rota. But I would feel there are some cases where you may have to combine a rota with an IVL. Rota for the superficial calcium and the deep calcium by IVL, and then deploy the stent, which would then expand to the fullest. Very well done, Dr. Gauri Shankar. You are in which town? I did not get it.
I'm from Visakhapatnam.
Okay.
Thank you. Thank you very much.
Done.
Thank you.
Thank you.
Well,
Thank you.
Dr. Omkar, can we
Yeah,
move to the next?
We can move to the next case. Dr. Vikrant Kese would be presenting next case.
Hello everyone, I'm Dr. Vikrant Kese. I'm practicing in Pune at present. Thank you Emcure for giving me this opportunity to present in front of the legends. Good evening everyone. So how do I share the slides?
I think you will be sharing, or my colleague would be sharing.
I have some clinical information and the ECG to show, and then Dr. Nanis will be sharing the videos.
Okay, so if you want to share, you can share from your side. Otherwise, she can share right now.
Yeah, I'll start my PowerPoint.
Yeah.
Dr. Omkar, why is this Ada? Like clinical stories with Dr. Vikrant and the
size, sir. Size, because of the size of the head.
Whatever. I mean, but anyway, let's Vikrant, let's go ahead.
Yes, sir.
Share the screen. Share the screen.
Is my screen?
No.
Good, Dr. Omkar, you have backup.
You first share the screen, then go to the PowerPoint presentation.
Vikrant,
Yeah.
having worked
Is it-
40 years in this business, it's good to have your technician next to you whenever you're presenting
Yes, I'm just starting.
national level meetings and international level meetings.
Yes, it's loading.
Yeah. Is it visible, sir?
You need to
Yeah,
switch
you
your
are sharing
screen.
the screen already.
Yes, now it's fine.
Yes, now it's ready.
So she's an elderly female, presented with inferior wall MI with no comorbidities. She was in a non-PCI center. She was thrombolized with tenecteplase. This is the ECG post tenecteplase around 90 minutes later, according to protocols. Still persistent chest pain with chest ST elevations. Echo showed basal septum and inferior hypokinetic with EF of 40. No mechanical complications were there. So because of chest pain and ST elevation, she was subjected to rescue PCR.
9:30, I finished.
So can we share the videos now?
Yeah.
Yeah.
So could you stop sharing your screen?
Yes.
So where are you expecting the lesion? RCA, circumflex?
Yes, sir. I am expecting a lesion in the RCA because the ST elevations in lead 3 are more than 2. There are few points there showing.
Nanit, you need to enable editing first and then only it will show.
So is it visible?
Yes, you need
Yes,
to
yes.
enable editing and then
Okay.
at the top you can see enable editing. Yes, and then share.
These are the two last, I think, ones. You have to show the whole thing.
Yeah. 1 second.
These are the two last two videos. This will show it later. The first. So these are the left-sided shoots. Patient had a 70 to 80% proximal and mid LED lesion. 60 to 70% of proximal LCX lesion. This is the RCA. Ostial lesion, ostial 90%, 80-90%, followed by a mid RCA 100% occlusion is seen, with some diffuse disease in between. So we started with a run-through wire initially. There was some difficulty in crossing the wire, so I parked that wire.
Dr. Vikrant, can you tell us a little bit about the left ventricle?
Yeah, sir, PF was 40%, sir. Basal septum inferior wall was hypokinetic, and there were no mechanical complications. There was mild MR, not significant. Otherwise, no complications were there mechanical.
The infarct is from the right coronary.
Yes, the infarct is right coronary. RCA is mid RCA is 100% occluded, sir. Next slide, please. Yeah, so we had wired it with a BMW wire. Because of the ostial lesion was there, I decided to balloon it first. Do I get some space? There was also wedging of the catheter, so I could have some space. So I dilated the ostial lesion first. Next.
What is the other precaution you can take if your catheter is
Catheter
getting
will be used.
Side hole catheters.
Yeah, it's a side hole catheter, sir. This is a side hole. So there was difficulty in crossing this balloon. It took some while to cross the lesion. This is a 210 balloon. I went up to 10 atmospheric pressure. I dilated the whole thing up to the ostium again. Next. Next. This was the tightest part I felt by crossing the lesion. Next. As it was a tighter lesion, it was difficult to cross that to 2O balloon also. I decided to pre-dilate with 2.512 balloon again. Next. Next. Sir, there's one slide missing. Sir, before this, this is the slide. So after dilating with 2.512, I took a stent of 335 or 0. The stent could not cross that point where the balloon was obstructed earlier. Manipulating that stent, pushing that stent, I lost my wire position and it came out. So I had to rewire it again. Next. So then I took a 313 balloon again and dilated it, the whole thing again. Next, the balloon pictures. There was some dissection in the mid RCA. So by this point, sir, there was a lot of dissection. I had taken a stent again, 335. I could not cross the stent again. I had to take out. There was a chunk of calcium there where the obstruction is there. Then we decided to go with a rota. This is 1.5 bar at around 1,60,000 RPM, around 25 to 30 seconds is subjected. Next. Next.
You have already used a 3 mm balloon.
Yes, sir. I had used a 3 mm balloon because
that was a NC or that was a regular?
It was an NC balloon, sir. 313 NC balloon. Wire was exchanged. BMW was parked in distal RCA. Yeah. So after this rota, again I took that 313 balloon. I had dilated the mid and the distal part of the RCA. Next. This is the post dilatation after the rota. Next. Yeah. But this time then I tried to pass that stent again, 335, that I could not cross from the distal RCA. I could not cover the lesion completely. Next. I had to dilate it again. Next. This is the stent I tried to cross. There was obstruction. I could not push it up to distal end of the lesion. Next. Yeah, I had dilated the lesions again, the distal part. This time I took a smaller stent on the next step with a guidezilla. Next. A smaller stent. It was a 322 or 0 that could easily cross them after that balloon. Next.
Why was your earlier stent not crossing and now this is crossing?
Sir, maybe
because you got a guidezilla.
Yeah, next time, this time there is a guidezilla, sir. This the 22-3 stent I had passed with the guidezilla. And I had pre-dilated it again then. It's too much of calcium. I did not expect this much of calcium. I could not see any calcium on the angiogram, like any. Next. Next, the stent deployed. This is the second stent I took. There's overlapping done. This stent I had already taken 335, so we had to use it. So we thought of using it there and taking another stent from proximal to ostium of the RCA. Next.
How much was the time gap between infarct and use of rota? That means gap between infarct and...
Yes, sir. So at 7 a.m. patient had chest pain. She presented to a non-PCI center. And around 11:30, I think she was on the table, sir.
Dr. Madal, doing rota...
Yes, sir.
In a AMI situation.
Yes, sir.
I mean, the artery was closed, so it was closed probably because of a combination of cholesterol.
Yes, sir.
And thrombus.
Yes.
And that's how you get an ST elevation.
Yes.
So I think putting in a burr at that stage is very
Sir,
risky because
at that point after wiring, nothing I could cross through that. The passing of balloon also was so difficult. Trying that 335 stent, trying a 322 stent from that mid RCA, it was very difficult and I could not cross. So at that point of time, managing that calcium, I thought Rota was a better. I was thinking of a balloon, cutting balloon, but I had already spent 2 hours before stenting that 322. So I decided to go with the Rota, and I had spent a lot of time already. So I didn't wanted to use.
Yeah, but what Dr. Hiramoto was trying to tell, whether
Yes,
you
sir.
should have gone for the Rota procedure or not in this background when the time gap is very less. This is number one. Number
Yes,
two,
sir.
if you have gone for the Rota, you should have done it rightly, so that you don't have sort of so many dissections and other things happening beforehand, and again you are putting the Rota and it is possibly incomplete. That's why you're getting difficulty in negotiating the different kinds of balloon, and you have to use the Guidezilla, which again adds to the cost. But definitely Guidezilla is a very, very good hardware for this kind of cases. If you would have gone for the Rota, then it should have done the proper job of making the bed appropriate for this deployment of the stent, actually. But
Yes,
that did not happen.
I want to show you next slide.
the
Next.
other thing is you should have used a Guidezilla before doing Rota. I mean, if you had got the Guidezilla deep in and then tried to push the stent through the narrowed portion, I'm sure it would have gone.
Sir, it was so tight even after the stenting. Next slide, please. Next 2-3 slides. You can skip the 2-3 slides. Yeah, even after stenting, sir, the lesion mid RCA still appears to be underdilated. The stent is not expanded. It was that tight that it was like a calcium nodule at that point. So it was difficult to cross anything to that. This was absolutely not expected. Even after this, I took a 3.25 8 balloon. I went up to 30, sir, for post dilatation also. Still, the results were very suboptimal. Next picture, please. Next, this is a 13 balloon, which earlier I had used. It's a 330 NC balloon, 313. Next, this I went up to 20, 22, 24. Next, next, next. This is a 3.25. Last slide, please. Last slide. It was a 3.258 up to 30 atmosphere pressure. Still, there is some under expansion of that stent.
But anyway, marks to you, because it's a huge artery.
Yes, sir.
You had left it, not taken her to cath lab.
Yes, sir.
I think it would have resulted into a very, very big infarct.
Yes, sir.
So all credit to you for going through these all these difficulties and getting a fully open artery.
Yes, sir.
How old is the case?
Sir, 2 months, sir.
Okay.
2 months. Yesterday, I did the non-culprit lesion. We did LED stenting. And I also have taken the RCA shoots. Can you see the next slides, please? Yesterday's shoots are there, sir. Next. This is the LED. Yesterday, I've done this, sir. Non-culprit. She is well, following up. She's discharged today morning, sir, from the hospital for this non-culprit. Next.
It's a very long stent.
Yeah. So 2 stents for the LED. 35, 2.25, 35 in the mid RCA, mid LED, and proximal 2.5, 15, 2 stents. This is the latest shoot.
2.25 in mid LED?
Proximal LED, sir.
No. You said mid LED was 2.25.
2.5, yes, sir.
And proximal was 2.5.
Yes, sir. Yes, sir. They were very small vessels.
I mean, I would probably feel that LED can be stretched, and any stent in LED would be about 3, a minimum 3.
On
Anyway.
calibration also, sir, the vessel sizes were around 2 mm. Still, I tried to keep it up slightly.
Anyway, at the end of 2 months, your right is holding very well.
Yes.
And that unexpanded area actually could lead to.
I was dilated with 2.75, that proximal LED, proximal stent. And the lower stent I had dilated with 2.5. Like that.
Dr. Nosundi, what is your experience? Like in this LED, we have 2.25 and 2.5 long stents. A good idea or not a good idea? Ronald?
In my opinion, it is not a very good idea to have the LED proximal lesion to be dilated up to 2.5. And since the size of LM is most of the time it's more than 4.5 or 5 or up to 6. So there will be definitely mismatch between the two, and automatically the LED is above 3 is always always the expected level of dilatation we ask for. So this is number one, and number two is that the long segment that was there with the LED, again 2 stents were put. So I don't know what is going to happen at later point of time when. Did you do the overlapping, or there was a gap between the two
overlapping,
stents?
Sir. I did the overlapping.
Okay, then if it is overlapping, then there is less chance of another stenosis to develop later on in between. Okay. Otherwise, so for the comment on the first approach is concerned, that is the right coronary artery, ultimate result was very good. There is no doubt about that. Though you took long time, ultimately the result was good. And so for the step care therapy or step care interventional techniques were taken, it was a very right decision. And only point is that possibly you could have dilated more on the proximal LED side.
So regarding this ROTA, now there are multiple registries come with where ROTA is being used in acute coronary syndrome or primary PCI approach. The outcomes have been similar, even though the mortality has been in-hospital mortality is slightly higher, but the 1-year outcome is absolutely unequal. It's equal in a stable elective ROTA as well versus in a primary PCI ROTA.
Yeah, there is no doubt about that the ROTA can be used in acute coronary syndrome. In fact, many cases, not many, some cases were presented even in CSI NIC also, where the ROTA, acute ROTA used in acute myocardial infarction setup was also demonstrated.
Yes.
And those who are very much confident, they can go for it. There is no doubt about that.
Yes, sir.
There is there are registry data which are coming up more and more.
Okay. Any questions, sir?
I think you have done excellently about the whole approach was very excellent. I like that you didn't go for the left coronary intervention on the day one itself along with the RCA. That should be the message to everyone, that it should be taken up in steps, and the point should be this point should be well taken. But my question now is non-interventional. So what's your take for the double pathway molecules for using in this type of cases?
Sir, regarding the antiplatelets,
Right.
yeah, we are using sir ticagrelol and ecosprin, irrespective of the type of PCR, complex or simple. Everyone.
No, that is well established. But are you going to use direct thrombin inhibitor or the other kind of factor 10 inhibitor in this particular case? Because the COPAS trial has shown enough results good.
Yes, sir.
And also, I want to listen from Dr. Hiremoth also on the same point.
So those with higher risk, we are using in some patients after 3 months. Sir. Initially, we are giving a double antiplatelet, that's ticagrelol. After that, aspirin plus single or anticoagulation. We have been using in few patients after 3 months.
Dr. Hiremoth is there? Yeah. Dr. Hiremoth, what's your experience with the triple antiplatelet therapy in complex cases?
Triple, what do you mean by triple antiplatelet?
Triple antiplatelet means DAPT plus this this band means band.
I mean, that means 2 antiplatelets and 1 anticoagulant.
Yes. Right.
So, I mean, there is one study where they have used 2.5 milligram twice a day of NOAC with DAPT. That is probably reasonable. I think you would probably need, Vikrant, you probably need to emphasize to the family and the patient that she should not stop Brilinta and aspirin for a long time, clearly 1 year.
Yes.
And probably continue it after that also.
Yes,
because
sir.
it's a thin diameter stents in LAD. And but Vikrant, I would feel I've never put even a 2.5 in LAD. So, and you have put 2.25 in LAD. So probably you need to.
So the vessel sizes were really.
No, don't go by what you see. I think you should understand that you should stretch. So that is how you. I mean, you have taken so much effort on LAD. So I think it would work very well. Safety is an issue, of course, and I would entirely agree. But you could take something like OPNNC and go high pressure.
Yes, the last time I was using OPNC, I ended up perforating the LAD. After that, I have not touched OPNC.
No. I don't think you should blame OPNNC.
At 35, it burst.
It's a 2-layered balloon.
Yes, sir.
And I mean, we go many times between 45 and 50 in that range too.
Last time I perforated at 35, sir. So I don't know what is that day. It may come, at 35 also you can burst. After that, I could not dare to, sir, personally, I could not dare to use that again. It was devastating.
I mean, you can't give up such an important technique just because one time you had an accident.
Yes.
I think try using it again. Next 50 cases, you will probably never have. I mean, it's like you start playing cricket. In the first game itself, you get out on 0. And you say, I'm never going to play cricket. It's not the story. So I think get back to using high pressures.
Yes, sir.
Okay.
Yes.
Thank you for this exciting case. And Dr. Omkar, we are done, or
Yes, yes,
we're done?
we have done for the day. So we can connect maybe next month, sir, about next 3 cases. So with this, I would like to take an opportunity to thank our course director, Dr. M.S. Hiremat, sir, and our course moderator, Dr. M.K. Das, sir, and Dr. Girish Navsundi, sir, joining this program and bringing a lot of discussion. And most importantly, I wish to thank all our speakers for the day, Dr. Abhishek, Dr. Gauri Shankar Reddy, and Dr. Vikrant Kese. So they brought 3 interesting cases which brought a lot of discussions and pearls of wisdom. So with this note, we will stop here, and maybe we will connect next month with 3 more exciting cases with a lot of discussions.
Thank you very much.
Thank you, everyone.
Thank you, Dr. Hiremat, and all other
and sir, we look forward, Das sir, we look forward to your kind presence in the next meeting as well, maybe for a few meetings coming forward.
Surely.
We keep one
Okay.
slot
Good night to
for
everyone.
Dr. Mrinal during the next meeting.
Yes.
We're telling you 1 month in advance.
Yeah, after 1 month, definitely will be much more relaxing, because we are now busy with the Chennai conference. A lot of issues are there with the Chennai CSI conference, and we are trying to sort out from the headquarters at both the ends.
Mrinal,
So we are quite.
Your hair have become
locked
gray. Fighting all these conferences. You are
Intentionally,
very
that
well,
is being kept like that.
you are deeply embedded it in. So there is no stress from Mrinal. No, you give him any difficult situation, he can come out very well.
Okay.
Thank
All
you
right.
very much.
Thank you.
Good
Thank
night.
you all
Good
the
night.
presenters.
And thanks
of
to all
course,
the
For your
speakers.
wonderful.
They have done excellent job. Fantastic cases.
Thank you, Dr. Omkar and
Thank you.
Emcure,
Thank
for
you.
bringing us all together.
Thank you. Thank you. Thank you. We'll stop here. Thanks.
Thank you.
RX, please stop live stream.